You want me to repeat it?
No, I think I understand the question. If a woman has cancer and it is detected that, if somebody says to you, I have cancer, and it was detected mammographically, that woman has incredibly good prognosis. If it's not detected mammographically, she has poorer prognosis. That doesn't mean that the mammogram did it. As Dr. von Eschenbach indicated, there are tumors that are relatively indolent, that are found with mammograms, that may not ever be found in the course of the woman's life. The autopsy studies have shown in the UK that women have as much as 35% invasive disease that never affected their health. There is a lead time bias. There is a lead time associated with mammography, that if you find it earlier, you may be, it's a very compelling notion. If you find it earlier, you may be able to treat it better. Does it really turn into a benefit? That's what the randomized trials are about. But there is a lead time bias. If you look at a woman and you find the woman, let's say 5 years earlier, that woman is going to live 5 years longer after you found the disease. That's one of the two biases I talk about in my report.
You said that in your statement, you said women with breast cancer detected mammographically have extremely good prognosis in comparison with those having cancer detected any other way. Mammographically detected tumors are smaller and are less likely to have spread to the axillary lymph nodes. Well, let me put it this way. I had a conversation with, yesterday on the phone with some breast cancer survivors in Iowa, and one woman said to me about false indications. She said, well, I'd rather have a false positive than a false negative.
Obviously.
Obviously. And so, again, you don't know, I don't know that there's any way to detect at an early stage whether a cancer is indolent or aggressive.
So far not.
So far not. So therefore, it would seem to me logical that if a woman could find a cancer earlier, not knowing whether it's indolent or aggressive, and it could be removed with the least invasive procedure, it would seem to me it'd be far ahead rather than waiting until later on.
If you could find the first cell that mutated, there's no question. The issue is when between that time and it becomes detectable by our current mammography, when between that time does it have a metastatic potential? And there we don't know. It may be already doing its dastardly deeds when it's only a few million cells, when it cannot be detected mammographically.
I don't know how to respond to that. But it would still seem to me that again, I just as a layman, it seems to me that the earlier, I've always been told, maybe, am I wrong in this, the earlier you can detect a cancer, the better your prognosis is going to be.
There's no question about that.
You said
the question is, does it translate into a benefit for mortality? There are examples, for example, the neuroblastoma issue, where we detected lots of cancer really early, and we found out that it didn't convert into a mortality reduction.
Well, I guess we're playing some kind of an odds game here. I don't like to put it in those terms. It just seems to me, again, that if I have breast cancer, and if I know that I wait, I know that it's going to metastasize at some point.
Not necessarily.
More often than not?
No, not, well, actually it depends whether it's detected mammographically or otherwise. If it's detected mammographically, fewer than 50% will ever metastasize. If it's detected otherwise, something possibly greater than 50%.
Well, if it's detected mammographically and with mammography and less than 50% metastasize, that's because something's been done, right? I mean, you don't just detect it with mammography and say, okay, we're not going to do anything.
The question is, Senator Harkin, what has been done? Several things have been done. One is that you found more cancer. And some of the cancer that you found may be incredibly important to find. I'm not saying that mammography is not good. It may be incredibly important to find. But some of what you find is not important to have found. The The problem is, of course, we can't distinguish which.
Well, again, okay. I know what you're saying you'd advise when you tell them all the odds and let them make up their own mind.
Yes.
But we're lay people, you know, we're not scientists. And we want to know what odds on, what's the best thing to do? I mean, you know, we look to the medical community for their advice and guidance and direction. And what I'm hearing from most of the medical people I talked to yesterday was that, as I said in my opening statement, was that mammography is not the sole thing, but in consonance with other things, it is a useful tool for early detection. And the earlier detected, the better your prognosis is going to be.
If a woman says, okay, you've told me all this stuff and it doesn't make any sense to me, just tell me whether to get a mammogram. And she said it to a doctor who has her best interests at heart, and the doctor says, I think you should get a mammogram, and she does, that's fine. I very much encourage that. But I want that woman to be exposed to, if she wants, all of the information that she can digest.
Thank you very much, Dr. Berry.
Dr. Berry, are you, do you counsel patients at all?
No, I do not.
Your training is a PhD in biostatistics.
That is correct.
And you're being asked questions really that center on a doctor-patient relationship, and you're answering it from a statistical data in your analysis of those.
That's why I put it in terms of my family, and my family listens to me.
I think just
always.
For the audience, it is very important, because if you hear a biostatistician looking at statistics and looking at both lead time bias in your explanation, which is very clear, and in your presentation and in your writing, I think we need to be very careful in posing hypothetical questions to you who, if you just listen, you might say, well, here's a clinician that says he doesn't really, in terms of counseling patients, should you get a mammogram or not? And really, you shouldn't be in that position in terms of clinical advice to a particular patient. And that's really what you're saying. You're saying take the information.
That is absolutely correct.
With that, if someone comes to a clinician and a clinician calls you on the phone, you basically tell the clinician what you've written here. Once again, you're not going to say whether or not that patient should get a mammogram or not. Would you ever feel comfortable being in a position of answering whether or not someone should get a mammogram based on the data out there? Again, recognize you're not a clinician. As a patient or as a woman who comes to you, or a man, that question is, should I get a mammogram? Are you comfortable advising them or counseling them at all, even given what you know?
If somebody were to come to me and say, I'm putting myself in your hands, you are to decide whether I get a mammogram.
That's correct.
I would run away.
Yeah. And I think that's right. I think that's the correct answer. Not for you. But it is a position that physicians are in, because they are looking at the biostatistical data. It's clearly confusing to the American people or people around the world, where the statistics are limited. They don't give the full answer. And in your written statement, you do make the statement, when it comes to inferring the benefits of screening, clinical observation is fundamentally subject to flawed interpretation. The implication to that, to me, is that one should not rely on clinical observation.
In the context of screening, it's very important in the context of treatment. A doctor gives Mrs. Smith a treatment and Mrs. Smith does well, he or she learns from that, and that's very important. And what I'm saying is you can't learn in screening.
And the biostatistician from screening looks at large populations in order to, which I think is potentially dangerous, inferring how you should treat a particular patient. And that's the implication in your testimony, in your written testimony. And I think that, to me, it's very dangerous as a physician to make that inference. It just comes, because what people are doing, they're listening to you, interpretation biostatistics, and they're taking it down to what you should advise an individual woman, and I think that's dangerous, and as a clinician. And I just wonder I ask your response to help me understand that. And I think that's what Senator Harkin's struggling with as well. And in his hypothetical question, you answered it, and I don't think you answered it appropriately, but I don't think it leaves the correct image of what we really need to answer, and that is an individual woman coming in, should you get a mammogram or not?